Well, I know we have more folks who will join us, I'm sure, as they come and join us as they're finishing up with their patients. But we have so much information to share in this session, and we want to make sure we have access to every minute of it. So I do want to welcome you all to this series that we're hosting on prenatal care, health, maternal health, primary care in your health centers. So my name is Alice Weingartner. I'm the Chief Strategy Officer here at Community Care. And just a few things we want to share before we start this session. We are recording it, so you will have the ability to watch it later or share it with others. And we'll make sure that it gets sent to you as well once it's done. We'll also be sharing the slides, which will be a great resource for you. We are keeping microphones muted, but you can certainly use the chat, or if you want to unmute yourself to ask a question during the Q&A time, we certainly welcome you in doing that. CEs are available for this series through the Weitzman Institute, and there are directions on the slides that you will receive on how to do that so you can claim your credit. You will have to create an account or log into the Weitzman Institute's platform and complete the post-session evaluation. The evaluation is going to be done following the series. We're not going to do one with each episode. So you will do it one time following the series. But for each session you attend, you can get a total of up to 4 credits. And we'll include all that information in the email that comes out as a follow-up email. We are really excited to host this series with you all. There is a lot of information that's going to be shared, and I will tell you a little bit about our speaker and how we got to where we are today. So Christina Carpenter is a physician's assistant with more than 20 years of experience in healthcare. She has spent 16 years practicing in outpatient obstetrics and gynecology before transitioning into her current role in gynecology at Penn State University Health Services, where she's been for the past 4 years. In addition to her clinical work, Christina is pursuing her master's in healthcare administration from Penn State University, an academic path that has helped inspire her involvement in this opportunity. And we got connected with Christina because she's been doing a similar series for the Pennsylvania Primary Care Association of Community Health Centers, and thought that breaking this down into 4 sessions would be really beneficial for you all. This session is packed. The first trimester has a lot of information in it. And so all of the slides will not be covered, but we will be sharing all of the slides with you. So I'm going to turn this over to Christina so she can get started and take it away.
All right, thanks, Alice. I'm so excited to be here, and ditto to what Alice said. This slide, when I gave it to the Pennsylvania crew, there's a lot. This is by far the longest one of the series. I will do my best to go through all of it. If I skip a slide, it doesn't mean that I don't think it's important. It's more or less that slide is relatively self-explanatory, and I know that you all are able to read, and so I will allow you to read it on your own time, and we'll kind of pursue into the next one. If you have questions, if you're watching the recording or you're looking at your notes and there's something maybe that I didn't cover well, please reach out to me. My contact information will be at the end, okay? So my disclaimer here is that all the data that I'm presenting is current as of today. Subsequent developments may affect the validity of the information. We know this. As you all know, medicine changes rapidly. And as providers, we all have our own ways of doing things. And I've done my best to present to you today's recommendations from some of the larger governing bodies in obstetric care. But I completely understand that there are amazing obstetricians out there that may counsel a little bit differently. And I recognize that these are our recommendations, and it is our job to educate the patients on recommendations. But as clinicians, we live in these communities with these patients, and we are familiar with some of the hurdles that they may be facing that might make the following recommendations just not realistic. And I know that your patients in Kansas are facing similar yet different obstacles to care as my patients in Pennsylvania. That is where our role as primary care providers is vital, right? We deliver longitudinal care. We truly know our patients, their histories, and the unique challenges that they're facing every day. And so although these are recommendations, there's always going to be shared decision making. And we can move on to the next slide there. So let's get started with today's topic, which is going to be that first trimester. Here you can see the trimester is kind of broken down for you. First trimester is going to be specifically from first day of last menstrual period up and through about 13 weeks and 6 days, or 14 weeks. We don't like to round up, I guess, in obstetrics. Moving on to the next one. So we're talking about the first trimester, which means that our patients will be in this kind of visiting every 4-week category. However, American College of OBGYN, ACOG, you'll hear me talk about them quite a bit. They're becoming vocal about supporting this tailored prenatal care. And this is really what's going to be meaningful for us in these rural communities. Most prenatal care providers have followed the traditional prenatal visit schedule. It does require significant effort and planning and even cost for the patient. And it's also a large use of resources, and there is really no clear evidence that it's beneficial. So in May of 25, so about a little over a year ago, ACOG released a clinical consensus that kind of breaks down their views on tailored prenatal care and what it might look
one
like.
meeting and now I'm in another one.
And you can actually find that in your references or in my references at the end. And I recommend checking it out. It's kind of a nice read when you get a chance. And we'll move on to the next one here. So our goals in the first trimester are listed here. We really like to initiate that care by 10 weeks of pregnancy, if possible. Moving on to the next one. So this is going to be the initial prenatal visit, and it's maybe the longest appointment with a provider that your patient has ever had, right? Sometimes they don't know what to expect. And so I do recommend trying to give your patient a heads up at the length of this appointment so that they can plan. If they're struggling with nausea and vomiting, they might need to have snacks along. They might not be able to go more than an hour without something small. Time off work, childcare. These are long visits to also be, entertaining another small child. So just kind of give them a heads up on that. All right, moving on to the next one. So in the very early part of your visit, you're obviously going to want to get some, you can go ahead and advance it there for me, Carrie. Are we stuck? There we go. All right, so early pregnancy vitals, you do want your standard height and weight, blood pressure, pulse, oxygen saturation, but you also want first day of last menstrual period. This is going to be huge. And please make sure it is the first day of their last menstrual period. People do tend to record the last day of their period, but we would like the first day. All right, so next slide there. Remember that only 1 in 20 women give birth on their actual due date. Back in the day, Nagel's rule, or even this fancy little pregnancy wheel is what we would use to kind of figure out the due date. Knowing the due date is important for appropriate testing and further management of the pregnancy. And if the patient is not sure of the first day of her last menstrual period and her cycles are not regular, generally you need about a 24 to 28 day cycle, then these methods aren't always the most accurate. And you're typically going to end up needing to order a dating ultrasound where they'll actually try to measure crown rump length of baby, which is going to be more accurate if the patient does not know last menstrual period or her cycles are quite irregular. Moving on to the next one, if you're like me and you don't like to do really hard math in front of a patient and you're not going to do that Nagel's rule, or you don't want to reach for one of the wheels, which I do tend to use those quite a bit, you can use an app to determine the due date. There's lots of due date calculator apps out there. Some you pay for, some are free. I recommend that you pick one, that's meant for clinicians and not just the general public, where the information that you're going to get will be, about what size fruit you should expect the baby to be at this point, and that's not overly helpful for you. I prefer one that has a capacity where I can kind of plug in not just the last menstrual period, but also like ultrasound results, like what day it was done, what the crown rump length was, and that will give me a due date. There's some of them that also you can plug in if they did IVF. You can base it off of the embryo transfer and the age of the embryo. And then some EMRs or electronic medical records also have the capacity to figure it out for you. So that's probably your easiest bet if you have that ability. So next slide. So these are the questions that we're going to want to address, right? These are going to be the questions that you're going to ask to kind of elicit the answers that you're looking for. I'm going to skip the next one just because you can read these. They're indications for ultrasound in early pregnancy. Patient history, this is very similar, as to when you're doing a new patient intake. You're going to want to get their demographics. These things are all going to matter with time. Also, moving on, you're going to make sure you have their allergies, their current medications, including non-prescription over-the-counter. Go ahead and move it forward. There you go, Carrie. Thank you. Their immunization history, if they know it, substance use, infection, toxin exposure, things of that sort is going to be important to elicit as well. And then we're going to move on to past medical history, chronic illness. I know scoliosis looks so strange on here, but I really use this because it matters for some patients if they can have an epidural or what kind of pain management they can have. If they've had back surgery because of the scoliosis, if they've been braced, whatever, sometimes they can. And this is useful information to know ahead of time versus the day of delivery. Okay. Remember that intimate partner violence is associated with an increased risk for low birth weight and preterm birth, and statistically does increase in pregnancy. So you do want to elicit some questions that may bring about these findings as well. All right, so screening for depression and anxiety, definitely changing gears a little. This does need to be done in the first part of pregnancy, as well as other parts of pregnancy, which we'll talk about in the other webinars. So the Edinburgh Postnatal Depression Scale, you may wonder why I have it here in the first trimester, and that's because it is great to do here to have as a baseline for comparison purposes later in the pregnancy or even postpartum. All right, so we're going to go on to the patient's obstetric history. So these are important because you need to kind of pull out, do they have a history of an ectopic pregnancy that's going to require you to really need to locate this pregnancy? Or are they at an increased risk for another ectopic? Obviously, we know that adverse outcomes in a previous pregnancy are going to increase the risk of those same outcomes in the next pregnancy. And so we need to be aware of things like gestational diabetes, history of gestational hypertension, preeclampsia, preterm labor, and spontaneous abortions. If baby was born with low APGAR scores or any breathing concerns in the newborn, these are all important. All right, we'll go on to the next one here. So this, I'm just going to skip through pretty quickly. This is also something you've probably seen in school. Remember, this is just how we write our nomenclature about OB history. Most commonly, we use our Gs and our Ps or our gravidas and our paras. This also is all about eliciting OB history. Just kind of the goal is you want to have a nice way to display it. This was taken from Cerner's EMR. There are many, many ways to display it, but you really want to be able to kind of see it nicely and easily and quickly in terms of their history. All right, so moving on, patient's gynecologic history. We've hit on a lot of these, but do make sure you find out about any history of sexually transmitted infections, including HSV, and any history of PID as well. And these are things that sometimes the patient doesn't mean to not tell you, they just don't remember, right? It happened a long time ago, they don't remember it, and you just have to kind of ask specifically. Family history, really want to kind of find out about any family history of birth defects. So any babies born on either sides of the family with any abnormalities that you're aware of is typically how I will phrase it. And then, kind of let the patient take the story from there. And sometimes you'll start hearing about things and they might not know exactly what it is, but sometimes as they describe it to you, you can kind of figure it out. Past surgical history up next. You just want to be very diligent about pulling out these very specific things and even down to any surgeries to the cervix, the uterus, the pelvis, anything of that sort. All right, lifestyle things, these are pretty common sense. Remember that whole issue with changing the litter box and gardening has to do with cat feces and toxoplasmosis. So you're really trying to screen if that's something you need to be testing for in the initial prenatal labs. All right, physical exam. This is your standard routine gynecologic exam. Do want to pay special attention to the uterine size and the shape of the uterus, and then evaluate the adnexa for masses, obviously. And then reasons you could find a discrepancy that are not bad would be things like uterine fibroids, the position of the uterus, if they're retroverted versus anteverted, or if it's a multiple gestation, you might feel like that uterus is bigger than you would expect it to be based off her last menstrual period. All right, next up, these are your most common initial prenatal labs. I will just leave those there for you. Moving on here, looking at the complete blood count, one of the more common complications of pregnancy is iron deficiency anemia. So figuring out the patient's baseline is important. Some women may not drop below the values that are given here. These are the ones used specifically for pregnancy, but they may drop pretty specifically or pretty significantly from their baseline. And so it's important to kind of recognize that. Because then if you need to check things like their, the B12 and their folate and ferritin and all of the things. So remember that due to increases in the plasma volume, you will see that dilution effect, and the hemoglobin is expected to lower during the pregnancy. However, physiologic anemia of pregnancy is really a diagnosis of exclusion, and you got to rule out all of the other things first. Remember that white blood cells will pop up a little bit in pregnancy. They will elevate. You can even see them up to about 16 and still be considered okay. All right, moving on to the next one. Important to get oops, I'm on the wrong slide. One second. Oh, blood type, yes. So remember the ISO immunization. Rh positive moms, nothing further that you need to do. If they are Rh negative and baby is Rh positive, mom can get exposed to some of baby's blood and she'll make antibodies against it. This isn't typically a problem at first. This is something that we see an issue later on, and we're trying to prevent hemolytic disease of the fetus and the newborn. That's the ideal. Remember the medication that we use is called Rogaine. And we give this to kind of help the antibodies not to be created later in the pregnancy, so then it's not an issue going forward. Perhaps a change for most of us who have been practicing a little bit is that routine Rogaine is no longer recommended for miscarriage or induced abortion or anything other than severe vaginal bleeding prior to 12 weeks. We used to give it in everybody under 12 weeks. We don't anymore. Recent studies show that the risk of alloimmunization before 12 weeks is extremely low, and fetal red blood cell exposure is below the threshold of sensitization. And so we don't do it. That's new and that's hard to follow. I think you probably still wouldn't be in the wrong for doing it. And you're certainly going to find clinicians who are still doing it because it is definitely how we were trained. And it's just ingrained in us at this point. But it is still indicated, after 12 weeks of gestation, especially ectopics, abortions, pregnancy loss, all of those things. You do still want to do it after 12 weeks for sure. All right, so on to the next one. Again, with the urine, important to get like a baseline assessment of renal function. Asymptomatic bacteria should be treated in pregnancy due to that like urinary stasis and that compression of the bladder. It's going to increase their risk for pyelo, which will increase their risk for preterm birth. And this is just not something we want to have happen if we could have prevented it. So ACOG does recommend treating a greater than 100,000 colony-forming units of a single organism. Also kind of a newer caveat, ACOG says do not treat group B strep bacteria of less than 100,000 colony-forming units. But do remember they are still considered group B strep positive for the pregnancy. So if their urine at the initial part of the pregnancy shows group B strep or GBS, They are deemed positive for the remainder of the entire pregnancy. Whether or not you have to treat them depends on A, symptom, and B, colony forming units. I again do still see some patient or some clinicians are treating GBS in urine at less than 100,000. All right, we're going to skip right through this because you guys can read. These are the treatments for asymptomatic bacteria in pregnancy. And then the last one is the treatments in terms of pyelonephritis. All right, and go on to the next one there, Carrie. Thank you. Same type of thing. Again, you guys can read here the treatments for GBS, group B strep in pregnancy. All right, rubella. So remember the big thing I want to point out on this screen is that positive rubella IgG indicates immunity, and this is the result that you are looking for. Patients will portal message you, they will call about this when they see it pop up that they're positive. Remember, that is the result that you want. If they're not immune, you're going to counsel them to avoid exposure to individuals with rubella, and then you're going to plan to vaccinate postpartum. Remember that MMR vaccine is not safe in pregnancy as it is a live vaccine. All right, moving on to varicella. Again, also a live vaccine, not safe during pregnancy. And we're checking the IgG antibody in this aspect. All right, next one here, hepatitis B. We are most concerned with a positive hepatitis B surface antigen. And obviously, if you get this, you're going to go on with more labs, just as you would in a non-pregnant patient. All right, we're going to move on here to HIV. I am going to discuss this one just a little bit because there's caveat to it. So an opt-out approach is what ACOG recommends. Go ahead and go back to HIV for me there if you can. Perfect. So screening should be performed after women have been notified that HIV screening is recommended for all pregnant patients and that they will receive an HIV test as part of their routine prenatal labs unless they decline opt-out screening. So they sign a waiver that they are declining it. The opt-out approach does achieve higher rates of testing in some studies versus the opt-in approach. You're going to see, much lower rates of testing, but you need to know your local regulations for patient notification for HIV and sign consent. Some areas, local regulation are still opt-in approach. They would need to sign to have the test completed. So they're not signing to say they don't want it. They're signing to say they do want it. So you just have to know your local regulations on this one. Retest in the third trimester if at high risk. All right, next one here. So syphilis. Rates of congenital syphilis are on the rise. They're no longer recommending the risk-based approach to testing for syphilis. All pregnant individuals should be screened at the first prenatal visit, followed by universal rescreening during the third trimester, and then sometimes at delivery as well. Most commonly, you're going to start with those non-treponneal testings first. If they're reactive, then you go to the treponneal test. And then obviously at that point, you're going to have the Department of Health on board to kind of help you through the management of it. Up next, treatment. You can see here right in front of you. Last I knew, Bicillin L, there's a shortage right now. And so I don't know how it is in your area. Last I knew there was a shortage of it, but Department of Health would help you figure out the dosing and get it for you. All right, next up, chlamydia and gonorrhea. ACOG says screen all pregnant women at the initial visit. No reason to, screen for those at high risk. Best to obtain it from endocervical swabs when you're in there doing the exam if you can. Try to avoid getting it from urine. If you're already going to be in there on a physical exam, I would prefer to do it from endocervical if you can. All right, this is just the, back up. This actually is to show that the CDC is changing, has their recommendations different from ACOG. They are just a slight difference. CDC cares about the age of the patient and their risk factors. So ACOG is everybody across the board gets screened. CDC still currently is not recommending everybody be screened. So I personally screen everybody for chlamydia and gonorrhea. in pregnancy. All right, these are the treatments. Not much else we need to say about that. There they are for you. Typically, complete a test of cure for chlamydia after treatment, about 4 weeks after in pregnancy, and then again 3 months after the treatment. It's a little bit different than if they're not pregnant. And then again, you're going to end up screening them at 36 weeks. So that last month of pregnancy, if they have a history of any STIs in pregnancy, you're going to end up screening them at the end again. So. All right. Tuberculosis, I am going to skip through this one a little quickly. Hopefully you're not seeing too much of it. Please contact your Department of Health if you have any suspicions or you're getting positive tests. Yeah, we'll skip through that one. And that treatment as well, you can skip. In terms of cervical cancer screening, obviously this is the good old pap smear. Perfectly fine to do this at the first prenatal visit. The frequency of when the testing is needed doesn't change due to pregnancy. So if they're on an every 3 to 5 year rotation, keep them on that. If they're not due for it, don't do it, okay? Abnormal results, however, are handled a little bit different in pregnancy. We don't tend to take biopsies of the cervix unless we're really seeing something concerning. When they're pregnant. If they're not pregnant, we do tend to biopsy if needed. All right. So on to a totally new topic, carrier screening. If a patient wants maximum information about baby's genetics, they should be pointed towards, an amniocentesis or a CVS, as these are going to give you your most helpful, useful, validated information. However, this is not where most of our patients are. Most of them are not going to want it. So just know there are very certain things that can be screened for. If a patient comes in and says, we have a strong family history of SMA, spinal muscular atrophy, cystic fibrosis, whatever, certainly Tay-Sachs disease, you can screen for these things specifically. Probably going to have maternal fetal medicine on board to kind of help you, or a geneticist with the screening tools, but this doesn't have to be done in everybody. Next slide, genetic testing. Biggest takeaway from this is it is not required. The patient needs to understand that the testing can be done for screening purposes, and some of the testing is done for diagnostic purposes, and they need to be educated about the difference between those things. Meaning, if you get this done and it's a screening tool and it is positive, that does not mean your baby has X, Y, and Z. That means we're probably going to have to go on for further testing. And if they say, well, I wouldn't do any further testing, then what is necessarily the point in having done the first one? So I just point that out there. It's all about patient education here. These are certainly not mandatory in any way. All right, I am going to spend a little bit of time on this next one, the cell-free DNA, because this is the one that patients will be asking you about because it is probably the more popular one right now. It's an example of a screening test. It is not diagnostic. It looks at cell-free DNA within the maternal circulation, screens for trisomy 21, 18, and 13, and then also sex chromosome aneuploidies, hence why the patients say, can I do that test that will tell me the gender of my baby? And that's all they want it for. They have to know if they're doing the test. It is also going to tell them other potential abnormalities. If we're to see a positive, we can't certainly keep that from them. So they need to know what information is going to be gained from this. If the test is positive, obviously an amnio or a CVS can be offered at any time for more definitive testing. Most patients won't go on to take that unless they have very specific concerns. Remember, though, that cell-free DNA detected from that fetal placental unit can be detected in the maternal blood as early as 5 weeks. And so some people really want to get it early, but most definitely you'll see it by 9 weeks. So we do try to push patients a little bit closer to that 9-10 week window for many reasons. But one of them is because if you do it too early, it's just not the most accurate of testing. Okay. Remember, it does not check for open neural tube defects like spina bifida. All right. Yes. So next one here, I wanted to just quickly go over if you get a result that says low fetal fraction. Fetal fraction is the percentage of cell-free DNA in the maternal blood that is coming from that fetal placental unit. Okay. These people are geniuses that come up with these things, I'm telling you. But you can get a result that says low fetal fraction or a no call or a no result. And the reasons for the low fetal fraction include things that are listed here, like testing too early, sample collection wasn't good, handling, whatnot. Maternal weight and obesity can affect fetal fraction due to dilution. You have to know that. Our BMIs are elevated across the country. My patients who are over typically a BMI of 30, I really will try to push them further, closer to 12 weeks if I can, 10 weeks sometimes, just because I'm afraid of getting this low fetal fraction, which means we have to repeat it. Um, uh, Waiting for that second trimester in obese patients can really help reduce that no-call result, and then also some provider and maternal anxiety. So basically, if they get a no call, you repeat it. If you get a second no call or low fetal fraction, then you start to get a little bit more concerned. And so I'm always trying to avoid the first no call if we can. Okay. This test can be done in a twin pregnancy. You just have to indicate that on the order. All right. I'm not going to spend much time on the next one, first trimester screen, because apparently that is now old school. Makes me feel old, although it is still available. And, it's an ultrasound and blood work. Pretty easy to do. And, we used it for years. So it is still out there. Measures that thickness on the back of baby's neck by ultrasound, non-invasive, and some maternal blood work. All right, patient education, another change of topic here. Just kind of go over the things. So abstain from alcohol, tobacco. Exercise in pregnancy is okay if they have no history of complications. So if they have a prior baby born with issues, or they've had greater than 3 miscarriages, or preterm rupture of membranes, preterm labor, history of cervical insufficiency, I don't want them lifting heavy weights, right? Or doing vigorous exercise. So we typically recommend low weight, lots of reps as the general exercise protocol in pregnancy. It's kind of boring, low weight, lots of reps, but it is typically the safer way. Other patient education things that are pretty self-explanatory. Remember, Tylenol, not ibuprofen if you can, and then avoiding that pseudoephedrine in the first trimester. All right, next one, self-explanatory vaccines in pregnancy. June? Yeah, just earlier this year, I believe. Yeah, ACOG updated their maternal vaccine schedule. It is different than the CDC's immunization schedule. So just be aware of that. ACOG is endorsed by many other professional medical organizations, including the American Academy of Family Physicians. And so they do tend to follow more the ACOG vaccine schedule. All right, I'm going to skip food safety in pregnancy in that you guys can read this one and it's self-explanatory. Foodsafety.gov, next slide, has a great handout about food safety, very colorful, fun to read. I do like that one. So next slide, nutrition in pregnancy. I am hesitant to give a calorie per day recommendation. Patients will ask you about it. It's so variable depending on maternal weight, their activity, number of babies they're carrying. It's variable. So it's really hard to give an exact calorie. I try to paint a picture for the patient that the calorie increase that you need is not as much as you think, AKA you are not eating for 2. This will definitely put you above the recommendations. All right. Folic acid recommendation does increase from 400 to 800 mcgs to 4 mgs, 4 milligrams daily, if they have a history of a neural tube defect themselves or a previous pregnancy with a neural tube defect. So remember that increase. 400 to 800 mcgs is standard. That's in most prenatal vitamins. If there's a history of neural tube defects, spina bifida, whatnot, you got to go to 4,000 mcgs or 4 milligrams. All right. Yeah, that's it. Go on to the next one there. Common complaints in the first trimester. You're going to hear all of these, right? You've probably experienced some of them yourself if you've ever been pregnant or had a friend pregnant. Breast tenderness for some women, they know they're pregnant without even taking a test due to their breast pain. It's very unique. We do recommend well-supported bras, wear them to bed. Some women will complain it'll wake them. It's so intense. Nausea, vomiting, and morning sickness, very, very common. Frequent snacking, you do need carbohydrates. Eating while still flat in bed, something bland like 3 or 4 crackers, let that get into your belly so it's not completely empty when you sit up. Does help a little bit with that nausea too. Obviously, stopping iron-containing vitamins can help, and then good old ginger, 250 milligrams 4 times a day, is a common one. First line pharmacotherapy for nausea, vomiting, vitamin B6, 10 to 25 milligrams every 8 hours. With or without the Unisom, you can do the combo. Diclegis is the combo together, sold together. And then lastly, if no relief, you're going to move to your dopamine antagonists like promethazine, the metoclopramide. You can move to those. Okay. Fatigue, make sure they are eating. It is okay to nap, but we recommend no longer than 30 minutes at a time so that they don't mess up their nighttime sleep patterns. Gingival bleeding, continue brushing through it. Some women will stop. Dental cleanings and dental care in pregnancy is so, so, so important. And so do let them know that that bleeding is common, but it doesn't mean that they should be stopping. Maybe a softer toothbrush, maybe less pressure, but they still need to be seeing the dentist and keeping up on their cleanings. All right, we're going to go on to the next very, very common topic or complaint, I should say, in early pregnancy. If you want to move to the next one, and that is bleeding and spotting in pregnancy. So this does occur in about 25% of pregnancies in the first trimester. Should be light. You want to try to characterize it if they can for you. Does it have pain? Does it not have pain? We do not do bed rest just because of vaginal bleeding anymore. Use of vaginal progesterone in a patient who has bleeding and has recurrent pregnancy loss may benefit them, but the use is controversial. So I do recommend if you're interested in that, look at some of the studies. There's a bunch out there, but vaginal progesterone is definitely on the radar. Yay and nay. The question most people think is it doesn't hurt, right? Vaginal bleeding is much less common in the second trimester, typically only about 1 to 2% of pregnancies in the second trimester. All right, this next slide, pretty self-explanatory. Bleeding in early pregnancy that is heavy. They have lightheadedness, syncope, pelvic, abdominal pain. These are ER types of visits. They need to be seen emergently. When evaluating patients with bleeding, I put this out here as a nice algorithm to follow and see if, sorry, screen's distracting me. Nice way to follow it. There's a lot of patients with bleeding in first trimester, and they will not follow this strictly, and you do have to make some clinical decision making. Do remember that there is no value in continuing to check a beta HCG concentration once the presence of an intrauterine pregnancy has been established by ultrasound. So some people will just keep checking it, feeling it's for reassurance, but that doesn't always help. So basically, once you have that ultrasound confirmed intrauterine pregnancy, you don't always need to be continuing to follow the beta HCG. So I'm going to move to that next slide. Yeah, there we go. Okay. So those last 2 slides were just the algorithm in terms of trying to work through first trimester bleeding. Feel free to utilize it. However, there will be some clinical judgment that is needed as well. This slide, I just want to say, the biggest highlight is it's important to note that the absence of an intrauterine gestational sac on ultrasound is highly suggestive of an ectopic pregnancy if that patient is by last menstrual period more than about 5.5 to 6 weeks. So you really need to be very cautious at making sure as you're evaluating these patients, do we know yet where the pregnancy is located? Have we been able to see it on ultrasound? If we can't see it yet, it may just be too early, but you have to keep checking. Okay. To the next slide. So fetal heart rate can typically be heard using a handheld Doppler device by about 12 weeks. Obviously, providers, as you do it more and more, sometimes on, especially on thinner patients, you can hear it as early as 8 or 9 if you get the right area and they got a nice bladder. Transvaginal ultrasound can identify fetal cardiac motion at about 5.5 weeks, right? It's pretty cool to see. Moving on, obesity in pregnancy. This does increase the risk for a lot of things, and we need to keep this in mind. Sometimes because it's so common, I think we take it for granted, but those things are listed here. OSA, remember, is obstructive sleep apnea. I should have put that out there. Pre-pregnancy obesity plus a high weight gain in pregnancy is your highest risk of pregnancy complications related to weight. And so you really need to counsel your patients who are coming in over their ideal weight about the importance of minimizing how much they gain during the pregnancy, but yet nutritious foods are important. So it is certainly a talk. So document their weight and height in the chart. Make sure you're using the appropriate blood pressure cuff size. That's always huge. And again, common sense, but we don't think about it. Probably going to need a first trimester ultrasound for dating. Please stop all weight loss medications. We don't have information. Well, I should take that back. We do have information on their safety, and we just don't think that they're safe at this point. So please stop weight loss meds. Any women who have had previous bariatric surgery, it's important to screen for nutritional deficiencies as they might not be absorbing as well. You're going to add on your labs to your prenatal labs, hemoglobin A1C, and or you could also do a 1 hour glucose tolerance challenge test. You do want to start them on low dose aspirin, 81 milligrams per day as prophylaxis for preeclampsia, as their risk is higher. We'll talk about that a little bit more at the end. I hope we have time. And then refer to a dietitian. It's never going to hurt. Weight gain recommendations in pregnancy, there they are. Patient's going to ask you about them. Feel free to utilize that. Moving on, anemia in pregnancy. You want to work up these patients just as you would if the patient was not pregnant, okay? You know what to do if they have, abnormal hemoglobin and hematocrits, looking at their MCVs. Are we worried about thalassemias? All that workup is still going to stay the same, okay? First trimester, you can typically treat with oral iron. IV iron can be used in the second and the third trimester if the hemoglobin drops below 10 or they're intolerant or they're not compliant with the oral iron. If they have malabsorption issues, you could consider IV iron. You can assess the response to treatment, looking for those increases in the hemoglobin level, usually, 2 to 3 weeks, and then that serum ferritin within about 3 weeks. IV iron patients typically don't recheck for 4 to 8 weeks after the infusion. And then once their hemoglobin reaches their normal range, oral iron replacement is continued for about 3 months or at least until 6 weeks postpartum. Remember the rationale, you guys know this from just general data, every other day dosing of iron, supposedly improving absorption and reducing GI side effects. All right, let's go on to pre-existing diabetes in pregnancy, also called pre-gestational diabetes. Goals here, you really, really want to have tight control of their blood sugars, monitor for maternal complications. That would be standard with diabetes in general, retinopathy, make sure they're up to date on their eye exams, their foot exams, all of the things. Hypoglycemia is going to be common in the first trimester for several reasons in these patients. They're going to they sometimes have decreased intake due to nausea and vomiting. That's one of the big reasons. Other reasons is they really have this increased effort to suddenly consistently achieve their glucose goals. Like this may be a patient that you've been struggling with for years to get them to achieve their goals. Now they're pregnant and they're like, I can do this. And so suddenly they're really on the game and they actually start to become hypoglycemic. So just be aware of that. Sometimes you have to give them permission to relax their goal a little bit to prevent that hypoglycemia as they kind of adjust. All right. So again, with these ladies, you're going to want your routine prenatal labs, hemoglobin A1C, all these other labs listed here, keeping them up to date on all their normal things, and then making sure you're getting their thyroid as well. One autoimmune disorder, typically another autoimmune disorder, you're going to want to check on that. Um, Patients with type 1 diabetes, they should have continuous glucose monitoring. Um, you don't have, they should review that with the provider, but it doesn't have to be in person. If there's a portal, if there's an email, if they can call them in weekly for review, that's perfectly fine too. And the biggest thing really is to have that collaborative care model. Like you're going to need yourself, endocrinology, diabetes nurse educator, if you have one, is huge, nutritionist, everybody kind of on board to help keep these, the regulation where we want it. All right, so these are the targets, your fastings, your 1 hour postprandials, your 2 hour postprandials. These are where we'd like our patients to be hanging out if we can. Moving on to the next, again, same with continuous glucose monitoring targets. Type 2, those targets are a little unclear. You want to have the majority of them, greater than like 70% of them within range. That's ideal. All right, pharmacotherapy. Insulin is preferred for hyperglycemia. Metformin is an option in some patients. Remember, they do need to be on low dose aspirin after 12 weeks. Again, we'll talk about that at the end. The non-insulin glucose lowering meds, GLP-1s, SGLT2s, all of those should be avoided. And then all your hypoglycemic issues are managed just using standard approaches. All right. Did I miss? Oh, there we go. Thyroid disease in pregnancy. I'm not going to say too much about it, although universal screening of asymptomatic pregnant women for hypothyroid in the first trimester is controversial. ACOG does recommend testing in women who have a personal or family history of thyroid disease, type 1 diabetes, or any sort of like clinical suspicion of thyroid disease. One thing I want to point out on this algorithm over in the hyperthyroid pathway is PTU. It is used in the first trimester because methimazole is associated with birth defects. Preference is to then switch to methimazole in the second trimester. PTU can cause some like hepatotoxicity that you just want to kind of be on the lookout for. All right, seizures in pregnancy, we're going to skip through this. Basically, no, they do sometimes increase. Medications typically need to be titrated, and neurology should be on board to help us with this. Asthma in pregnancy, I do tell my patients if mom is not getting oxygen, baby is not getting oxygen, you do want to try to keep their asthma controlled and try to prevent acute exacerbations if possible. They end up hospitalized quick. They could say they were a very well-controlled asthmatic, and when they're pregnant, it's just out of control. That's not uncommon. But otherwise, treat them as you would a non-pregnant patient with kind of a stepwise approach, short-acting beta agonists or combi inhalers. If they do end up on a steroid for control kind of long term, you do want to watch fetal growth in the second and third trimesters with ultrasounds. However, in most cases, the risk of fetal growth restriction is worth appropriate oxygenation. And you do have to make sure you remind your patient of that because they think they're harming baby and they won't use their inhaler. They're like, I can breathe, sort of, and they won't use it, but they really should be.
Christina,
Yes.
we have a couple questions in the chat, and I didn't
Okay.
know if we were getting to a point where we might want to start taking questions or if there's a few slides that you still want to absolutely cover in the time that we have left.
All right, asthma we talked about. Is the next one the low dose aspirin, I
It
think?
is.
Let's do that quick, just because that's
Okay.
kind of a hot topic.
Okay.
I mentioned on a few slides previously, low dose aspirin, also referred to as baby aspirin, in preeclampsia prophylaxis has been a hot topic in the last few years. These recommendations here are through ACOG, American College of OBGYN, and Society for Maternal Fetal Medicine. They both agreed on these kind of classifications. So listed here, these women who are at high risk for preeclampsia, they just need to have one of these listed to be placed on aspirin therapy. If you go to the next slide, these are considered moderate risk, and they need to have more than one of these, one or more, to start aspirin therapy. So those two societies did agree on these kind of recommendations for low dose aspirin prophylaxis. Having said that, what dose you should use is still controversial. Regardless of the dose, they do recommend starting it before 16 weeks to actually get benefit. If you start it after that, we're not seeing the benefit. Most people are starting closer to 12 to 14 weeks. 81 milligrams is most commonly used. It is becoming more common to use 100 to 150. However, those doses aren't really available in the US, so most patients are then just put on 162 milligrams a day. Seems to be becoming the new norm. So interesting stuff coming out on this, and everyone is doing it a little bit different. But ACOG and Society for Maternal Fetal Medicine did break down the risk factors and who should definitely be on it. High risk versus moderate risk. All right. I hate to skip chronic hypertension.
And we can, but there's two questions in the chat. So I don't know if you want to address those and then continue on with a few more slides. We have about 6 minutes left in the hour.
Yeah, let's get chronic
And
hypertension in here then first,
oh,
I think. Okay. So all patients should be screened for hypertension, obviously, at their first prenatal visit. You want to discuss any family history of hypertension, problems with their blood pressure they may have had prior to pregnancy. Again, as we talked about, make sure that you're using the appropriate blood pressure cuff size. Do remember that a reduction in blood pressure early in pregnancy is a normal occurrence. So some women will look like they have kind of like an undiagnosed chronic hypertension because they might be normotensive at their first prenatal visit. Then as the pregnancy progresses, their blood pressure actually starts to come back up to their baseline and they're actually a chronic hypertensive. But you, of course, will start to wonder, are they developing preeclampsia? Are they developing gestational hypertension? What's happening? Another perk to being their primary care, hopefully you've seen them in the past and you have some readings that you could kind of compare, and that's helpful. Hypertension diagnosed or present before pregnancy or at least 2 occasions before 20 weeks is considered chronic hypertension, or hypertension that is first diagnosed during pregnancy and goes on for greater than 12 weeks after delivery is chronic hypertension. Okay. These are the values most commonly used. Chronic 140 over 90, severe value 160 over 110. Severe values do need to be treated regardless of the reason why it is severe. This criteria came from the CHAP trial, which is the chronic hypertension and pregnancy trial. I encourage you to look it up. It's kind of a cool read, to me at least. ACOG, because of the CHAP trial, ACOG and Society for Maternal Fetal Medicine changed the threshold for initiation and titration of medical therapy for chronic hypertension in pregnancy should be 140 over 90 and not the previously recommended 160 over 110. That's the key takeaway from this. Risks, you guys can read these. These are just scenarios. They're pretty self-explanatory. If they have this, then this. Medications, they're going to want to be on baby aspirin, and meds are listed for you there. Labetalol and nifedipine are your big ones. Differential diagnosis. Sorry, I'll let you move forward there. Those are the treatment scenarios. You can roll through that one. You guys can read those yourself just to kind of save time. Medications, again, there's the baby aspirin, first line, labetalol, nifedipine. Then you've got your acute lowering meds. Go ahead and move forward. Differential diagnosis, you guys can go through that. Make sure that you have considered secondary causes of hypertension, right? We don't want to miss the obvious secondary causes. Okay, go on to the next one. Monitoring, I'm going to skip this. There are extra monitorings that you do on patients with chronic hypertension. You can kind of read through those. BPP stands for biophysical profile. That involves an ultrasound. NST stands for non-stress test. That does involve a machine that's strapped onto the mom's belly. Timing of delivery spelled out for you here in terms of which scenario your patient is following in. Medication safety in pregnancy, there's an app called Infant Risk for healthcare providers. That's probably one of my favorite ones, and I do use that quite a bit. All right, does that give us any time for questions?
We do have a couple of minutes, so I'm going to read the questions that are in the chat. And then if anybody else has any questions, please don't hesitate to either put them in the chat or raise your hand and we'll call on you. I think this question got answered earlier, but it was, do you recommend doing a pelvic exam with all pregnant women, even if they are not due for a PAP?
Yes, pelvic exam is important because it's showing you so many other things in terms of the look of their cervix. When you do the bimanual exam, you can feel, sometimes you'll feel a shortened cervix and you're like, this is not a very thick cervix for a new pregnancy. And that makes you start to question, is something up? And then obviously bimanual exam, adnexal masses, right? If you can feel an ectopic, you're golden. So yes, I definitely recommend a pelvic exam, pregnant women, even if they are not due for a pap smear.
Okay. The other question was, do you have any thoughts on the G mycoplasma screening in urine vaginal swabs as a screening lab?
Yeah. Do I have thoughts? Yes. Can I give you the data right now? No, without looking it up. We come across this a lot in just general gynecology right now, right? Not even pregnant patients. Um, the data that I really want to dive into is what numbers are we seeing in coordination with preterm labor risks? I do not routinely swab for mycoplasma or ureaplasma in pregnant women. I don't think the data supports it right now. I am more than willing, if someone does have some articles that they've come across, I would love to read through them. It's been on my list of things to do this summer. Again, it's controversial even in just straight gynecology. In pregnancy, I do worry about it more because I want to know its association with preterm labor. I think that's our biggest thing. And like chorioamnionitis, endometritis, are we seeing increased risks there in terms of maternal infection? As far as I know so far, we are not. But I don't think we have a set protocol on who should be screened or who's considered high risk, right? I think someone who maybe has had a history of recurrent chlamydia and gonorrhea, maybe a history of PID, you wouldn't go wrong screening them. But if it's just your general patient who claims no history in terms of STIs, not multiple sexual partners, I'm not sure it's going to be overly helpful right now.
All right. Well, Christina, thank you so much for your presentation and for answering the questions that were asked. I'm sure as we move on through this series, we'll have more questions along the way. I do want to thank all of you for participating today in this first part of this series. We will send an email, as I said earlier, that will have the slides, the recording, information about how to claim your CE credits, and that will come out in the next few days. You can see on your screen when the next session is, July 8th at 12 o'clock. And we look forward to seeing you then. And we hope that everybody has a great rest of their day.
Thanks for coming, everybody.
Thank you so much.
Thanks.